Okay, good morning, everybody. So today I thought we could talk about major and mild neurocognitive disorders for exams and memorization. My name is David Patrician. I'm a third-year psychiatry resident at the University of Saskatchewan. This presentation will take between 60 to 90 minutes to complete. For objectives today, number 1, list the 6 cognitive domains and name at least one element of each. Number 2, become familiar with DSM-5 criteria for delirium and specifiers. Number 3, become familiar with prevalence and risk factors for delirium. Number 4, become familiar with DSM-5 criteria for major and mild neurocognitive disorders and specifiers. And we're going to do this through illustrative clinical cases. All of the statistical information presented here is from the DSM-5 Treatment Revised Edition. So first, some background information. Why talk about cognitive domains? The main reason we talk about cognitive domains here is because they're implicated in almost all of the diagnoses we'll cover in this chapter, often under the criteria A. So let's get into some cases. Case 1, the case of Catherine Arnold. You're working with Miranda Akeen, CC3, on your geriatric psychiatry rotation at City Hospital. Your preceptor has asked you to see Catherine Arnold, an 84-year-old woman who has been referred for the chief concern of memory problems. Miranda asks, when I was going over my psychiatry notes from class, I noticed that some of the major and mild neurocognitive disorders require problems in more than one cognitive domain for diagnosis. What are the cognitive domains we should know about? And so my question to you would be, what are the 6 cognitive domains mentioned in the DSM-5? So the 6 cognitive domains are complex attention, learning and memory, language, executive function, perceptual motor, and social cognition. The mnemonic I use is P-CELLS, which stands for perceptual motor, complex attention, executive function, learning and memory, language, and social cognition. Next, we will work through a series of 6 cases to familiarize ourselves with the individual elements of each one of these cognitive domains. After each case, we'll talk about the differences patients with major and mild neurocognitive disorder might present with in terms of deficits in that particular domain. Now back to Catherine Arnold. On history taking provided by both Mrs. Arnold and her brother Larry Mason, you learned that she has been having increasing difficulties with getting things done, such as when she was doing laundry and preparing a meal at the same time. Initially, Larry noticed that Catherine was taking longer to finish usual tasks and would spend hours double-checking her budget and bank statements. He also reports frustration in communicating with her. He tells you, it's as if things go in one ear and out the other. As you were speaking to Catherine, the floor cleaning machine can be heard outside the room, buzzing noisily. Catherine is obviously distracted by this, and the quality of the interview suffers. Miranda is eager to interview, and it is obvious that Catherine has difficulty with lengthy, open-ended, double-barreled questions. In responding, you note that it often takes much longer than expected for Catherine to answer even simple questions. What elements of complex attention does Mrs. Arnold appear to be struggling with? Let's take each of these in turn. The first is sustained attention. This is the maintenance of attention over time, such as paying attention to Larry when he speaks at her at length, described by him as in one ear and out the other. The next is selective attention. This is the maintenance of attention despite competing stimuli and or distractors, such as attending to conversation when the floor cleaner passed by the room. The next is divided attention. This term is used when attending to 2 tasks in the same time period, as described by Larry as difficulties getting things done. And the last is processing speed. This is the time it takes to accomplish a task, such as speed in responding to a question. In order to remember these components of complex attention, imagine talking to your partner at a four-way stop. On your left, two children are crossing the street and eating ice cream cones. It's your turn to go, and just as you do so, a car runs the stop sign passing in front of you. The child, now safely across the street, drops their ice cream cone, and you slam on the brakes. This is an example that involves all the elements of complex attention. Individuals with mild neurocognitive disorder who have difficulties with complex attention may start to find errors in routine tasks, notice that usual tasks take longer than they used to, and that their work requires more double checking than before. In terms of thinking, they may notice that it is easier to think when they are not competing with other stimuli. Comparatively, an individual with major neurocognitive disorder may have difficulties in environments with competing stimuli. They may be easily distracted by other stimuli. They may be unable to attend unless input is simplified. They may have difficulties with mental calculations, holding new information. Thought may seem slowed, and processing speed may be reduced. From our short interaction with Catherine Arnold, we are able to satisfy the subjective part of the diagnostic criteria for neurocognitive disorder. Next, we'll talk about the case of Eric Fisher. Eric Fisher is a 74-year-old man who presents to the emergency department accompanied by his wife Lorna with the chief concern of not coping at home. Lorna is tearful and frustrated. She shares with you that things have been getting worse over the past several years. He won't leave the house anymore, and all he does is lay around on the couch. He used to love working on his car and following the stock market, but for months he hasn't been doing any of that. To make matters worse, he has missed several bill payments because of careless spending. He even has trouble getting dressed in the morning. Last weekend I told him to get ready for church and thought he was upstairs getting dressed. But an hour later when I went up there, he was just sitting on the bed in his underwear with a tie carelessly knotted around his neck. There was clothing scattered all over the room. I just can't take it anymore. In interacting with Mr. Fisher, you find him to be a pleasant gentleman. On examination, he has difficulty switching from ordering objects by size to ordering them by color, despite your attempts to reiterate the objective of the task. He is also unable to repeat a series of numbers backwards on command, instead repeating several digits forwards before giving up. What elements of executive function does Mr. Fisher appear to be struggling with? Mr. Fisher appeared to have difficulties with a number of elements of executive function, which we'll now review. Planning includes such things as finding the exit to a maze or interpreting a sequential picture. Here Mr. Fisher had difficulty applying clothing in the correct order, that is, putting a tie on before putting on his shirt. Decision-making is the ability to perform tasks despite competing alternatives, such as choosing what to wear. Mental or cognitive flexibility is the ability to shift between two concepts, illustrated by difficulty ordering objects by size to ordering them by color. Feedback or error utilization is where someone takes feedback and is able to correct performance. Mr. Fisher continued to make the above mistake despite reiteration of the objective of the task. Working memory is the ability to hold information for a brief period of time and to manipulate it, such as repeating a series of numbers backwards on command. Although not illustrated here, another element is overriding habits or inhibition. This is the ability to choose a more complex and effortful solution to be correct. For example, looking away from the direction indicated by an arrow, or naming the color of a word's font rather than naming the word itself. Mnemonic to remember the different elements of executive function is wide frame, which stands for working memory, inhibition, decision-making, error utilization, and cognitive flexibility. An individual with mild neurocognitive disorder who has difficulties with executive function may find that it requires more effort to complete multi-stage projects. They may have noticed increased difficulty multitasking or resuming a task interrupted by other stimuli. They may complain of increased fatigue from extra effort to organize, plan, and decide. And they may report large social gatherings are more taxing and less enjoyable due to having to shift mindsets and follow conversations. An individual with major neurocognitive disorder and problems with executive function may find that they abandon complex projects, that they need to focus on one task at a time. They may rely on others to plan IADLs, and they may rely on others to make decisions. From our short interaction with Eric Fisher, we were able to satisfy the subjective part of the diagnostic criteria for neurocognitive disorder. Next, let's discuss case 3, the case of Larry Mason. You're rounding on Catherine Arnold with Miranda, the ZC3. As you approach the patient's room, you overhear an argument between Catherine and her brother Larry. Just as you are about to enter, Larry storms out, mumbling under his breath. He pushes past you and heads down the hallway. Nearing the end of the hall, Larry pauses and scratches his head. Now how the hell do you get out of this place? Inside the room, you find Catherine and a nurse who is adjusting a blood pressure cuff. Speaking with Catherine, she tells you that Larry became angry with her after she asked him questions about his granddaughter's upcoming wedding. The nurse tells you that Catherine had asked him the name and address of the wedding venue and the dates that they would be away on their honeymoon. It was surprising how mad he became. It's odd, the nurse tells you. He was just on the phone with his granddaughter, and I'm sure she told him, because he repeated the question several times. What elements of learning and memory does Mr. Mason appear to be struggling with? Mr. Mason appears to be struggling with immediate memory span. This is the ability to repeat a list of words or digits, such as the dates the couple will be away on their honeymoon. He also appears to be having difficulties with recent memory. Tests of recent memory assess the process of encoding new information, such as the name of the wedding venue. There are several elements subsumed under this heading. These include free recall, cued recall, recognition memory, semantic memory, autobiographical memory, and learning, all of which are described in a table at the end of this presentation. The mnemonic for learning and memory is RIMS, which stands for recent memory and immediate memory span. An individual with mild neurocognitive disorder who has difficulties with learning and memory may have difficulty recalling recent events and relies increasingly on lists or calendars. They may require occasional reminders or rereading to keep track of characters in film or book, and occasionally may repeat themselves over a few weeks to the same person. They may also lose track of whether bills have been paid. Comparatively, a person with major neurocognitive disorder with difficulties of learning and memory may repeat themselves in conversation, often in the same conversation. They cannot keep track of a short list of items when shopping or of plans for their day, and they may require frequent reminders to orient themselves to tasks. From our short interaction with Larry Mason, we might start to wonder about the subjective part of the diagnostic criteria for neurocognitive disorder. Next, we'll talk about Lorna. You're a PGY1 psychiatry resident currently rotating in neurology, and you're having a wonderful time. Your senior resident has just notified you of an incoming stroke alert for a patient named Lorna. By description, you're able to discern that this is the same Lorna who brought her husband Eric Fisher to hospital in case 2. What a small world. On initial assessment, Lorna is unable to tell you the name of your wristwatch, pen, and cell phone, and erroneously refers to the paramedic as a firefighter. By all accounts, it seems she is able to understand your requests and seems concerned with her inability to be understood. What elements of language does Lorna appear to be struggling with? Lorna appears to be having some difficulties with expressive language. This is assessed by confrontational naming and fluency. Here, Lorna has difficulty producing the names of common objects. She also appears to be having difficulties with grammar and syntax. Errors observed during naming and fluency, such as referring to a paramedic as a firefighter, support this. Although not present in this case, another important language function is receptive language, also known as comprehension. This can be assessed by asking a person to perform an action according to verbal command. Again, receptive language deficits were not evident in the case of Lorna. The mnemonic to remember elements of language is eager to speak, the E representing expressive language, the G representing grammar and syntax, and the R representing receptive language. In an individual with mild neurocognitive disorder, language disturbances may take the form of noticeable word-finding difficulty. Individuals may substitute general for specific terms. They may avoid specific names of acquaintances. And they may use grammatical errors which involve subtle omissions or incorrect use of articles, prepositions, or auxiliary verbs. Individuals with major neurocognitive disorder and issues with language may have significant difficulties with expressive or receptive language. They often use general phrases such as that thing and you know what I mean. They prefer general pronouns to names. They may use idiosyncratic words and make grammar errors. Stereotypy of speech occurs, and eventually echolalia and automatic speech occur and precede mutism. From our short interaction with Lorna, we might start to wonder about the subjective part of the diagnostic criteria for neurocognitive disorder, but it's too early in her illness course to know if deficits will endure. Case 5 is the case of Peter Malloy. It's another busy day on your neurology rotation, and you've been asked around on a new patient admitted last night. Peter Malloy is an 84-year-old retired police officer, and you find out from some of the older nursing staff that he was a bit of a celebrity in the 70s. One of them shows you a news article titled, "Car Chase Ends in 4 Arrests," which goes on to describe Officer Malloy's driving prowess. On further review of the chart, you learn that Mr. Malloy was admitted due to seizures secondary to MS and has history of an anterior temporal lobe meningioma resection 15 years ago, which left him with face blindness. His daughter, Susan Christensen, is at the bedside and reports that prior to admission her father had been experiencing progressive cognitive changes, and she is hopeful that you'll be able to diagnose him with something. She describes her father as making errors in buttoning his shirt and finding his way whilst out on walks, especially at night. Mr. Malloy smiles as you introduce yourself and attends well to your conversation. When asked to bisect a line in the center, he has a clear preference for the left side. When asked to draw a cube, he has obvious difficulty. And when you ask him to imitate your hand gestures, he similarly has trouble. What elements of the perceptual motor cognitive domain does Mr. Malloy appear to struggle with? Mr. Malloy appears to have difficulties with visual perception. This can be assessed via line bisection tasks. Here, Mr. Malloy appears to have attentional neglect given his preference of the left side. Visual constructional, this involves the assembly of items requiring hand-eye coordination, such as drawing or copying, as seen here, with instructions to draw a cube, which was done quite poorly. Praxis, this pertains to the integrity of learned movements, as shown here with the request to imitate common gestures like waving. And finally, gnosis, this pertains to perceptual integrity of awareness and recognition, Mr. Malloy has prosopagnosia, that is the inability to recognize faces. The mnemonic for these elements is very good people visit, standing for visual perception, gnosis, praxis, and visual constructional. An individual with mild neurocognitive disorder and difficulties with perceptual motor cognitive domain may rely more on maps or others for directions. They may use notes and follow others to get to new places. They might find themselves lost or turned around when not paying attention or concentrating on the task at hand. They become less precise in parking, and they need to expend greater effort for spatial tasks such as carpentry or sewing. Individuals with major neurocognitive disorder may notice significant difficulties with previous familiar tasks. They may notice difficulties navigating in familiar environments. And they're often more confused at dusk when shadows and lowering light change perception. From our short interaction with Mr. Malloy, we might start to wonder about the subjective part of the diagnostic criteria for neurocognitive disorder. Next, we'll turn our attention to Susan Christensen. Towards the end of your assessment, Mr. Malloy's daughter Susan asks to speak with you in private. You're rather surprised at the immediacy of her request, as Mr. Malloy has just begun tearing up and crying loudly after sharing how much he missed being able to drive a car. Hesitantly, you oblige Mrs. Christensen and escort her to the family room to converse. She tells you, "I just don't understand why I have to put up with him. It's so hard for me. I'm a busy person, he's such a drag to be around." Feeling awkward, you try to redirect her by asking about his tearfulness. "Crying? I didn't notice he was crying. Why should he be upset?" You begin to suspect Susan is lacking in the domain of social cognition. What are the two elements of social cognition discussed in DSM-5? Well, they are recognition of emotions, which involves identification of emotion in images or faces representing both positive and negative emotions. Here, Susan did not seem to notice how distressed her father had become. And theory of mind. This is the ability to consider another person's mental state or experience. Here, Susan asks, "Why should he be upset?" after you had discussed an emotional topic. A mnemonic to remember these is TEAR with a capital T for theory of mind and a capital R for recognition of emotions. An individual with mild neurocognitive disorder who has difficulties in the social cognition domain may exhibit subtle changes in behavior or attitude, which are often described as a change in personality. Comparatively, an individual with major neurocognitive disorder may exhibit behavior that is clearly outside the acceptable social range. They may demonstrate insensitivity to social standards of modesty or dress, or in terms of topics of conversation. They may focus excessively on a topic despite group disinterest or direct feedback. Decisions are often made without regard to safety, and they have little insight into these changes. From our short interaction with Susan, we might start to wonder about impairment in the social cognition domain. Now on to part 2, where we'll talk about delirium. Core feature of delirium from DSM-5 TR is a disturbance of attention or awareness that is accompanied by a change in baseline cognition that cannot be better explained by a pre-existing or evolving neurocognitive disorder. So let's use a case to illustrate delirium. You are a PGY4 resident currently participating in your CL rotation, and you've been asked to see CN, a 65-year-old post-operative patient who's had a prolonged stay following a hip fracture 2 months ago. Reviewing the chart, you see that all vital signs are within normal limits, except for temperature, which is elevated at 39.5. CN has been laid up in bed, and their immobility has necessitated DVT prophylaxis. You see that their BMI is 38, Their medical history is significant for OSA and major depressive disorder treated with sertraline and low-dose aripiprazole. After assessing CN, you come to the conclusion that they are experiencing delirium, possibly of an infectious nature. You write as much in your consult note and head back to cafeteria for lunch. Whilst chowing down, your phone rings. It's the ortho resident who requested the consult. They express disdain that you aren't willing to transfer the patient to the psychiatric unit and ask you to explain why you think CN meets criteria for delirium. What are the DSM-5 diagnostic criteria for delirium? Well, they must have impaired attention and awareness, which develops over hours to days, and a change in cognition from baseline and between night and day. The change in cognition must take the form of one of the 6 cognitive domains, and it cannot be due to another neurocognitive disorder or coma. It must be the pathophysiological consequence of something else. After listening to your description of the diagnostic criteria for delirium, the ortho resident agrees with your diagnosis. Ortho resident. Wow, Dr. Psychiatry resident, you sure seem to know a lot about delirium. I wonder if you can tell me some more about delirium. Specifically, what are some of the risk factors for developing delirium present in this case? How common is it? Risk factors for delirium include functional impairment, immobility, history of falls, low level of activity, psychoactive medications, history of major or mild neurocognitive disorder, and older age. Community prevalence is between 1 to 2%, and then this increases with age. Prevalence in admitted patients is 14 to 24%. As a mnemonic for risk factors, imagine an obese 85-year-old patient admitted to the mental health unit with schizophrenia and a broken hip treated with high-dose quetiapine. Now back to the case. Ortho resident. Thanks so much for that, it's super helpful. By the way, is there any way you could make that diagnosis more specific? Delirium just sounds way too vague. Is there something better I could use to impress my attending? What are the 3 types of specifiers that can be applied to delirium? Well, you can specify the cause, which can be substance intoxication, substance withdrawal, medication induced due to another medical condition or due to multiple etiologies. You can specify type. It can be hyperactive, which is characterized by increased psychomotor activity. It can be hypoactive, which is characterized by reduced psychomotor activity, or it could be mixed level of activity, which means there's either normal activity or fluctuation. You can also specify acuity with acute, lasting hours to days, and persistent, lasting weeks to months. We'll just finish off this with 2 pearls. So, I watch death is a common mnemonic to remember different causes of delirium. It stands for infectious, withdrawal, acute metabolic, trauma, CNS pathology, and hypoxia, deficiencies, endocrinopathies, acute vascular toxins or drugs, and heavy metals. A common exam question regards the EEG findings associated with delirium. Most commonly, it's generalized slowing, although fast activity occasionally is found in alcohol withdrawal delirium. If you're asked how long delirium usually lasts in hospital settings, the correct answer is about 1 week. And finally, for completeness sake, we'll talk about other specified and unspecified delirium. The common feature between them being that there are symptoms of delirium which result in functional impairment, that the individual doesn't meet criteria for any disorder in the neurocognitive disorder diagnostic class. If the clinician chooses to communicate why they don't meet criteria, other specified is used. If the clinician chooses not to communicate the reason why, or there's not enough information, then they use unspecified. And now on to part 3, where we'll spend the bulk of our time talking about major and mild neurocognitive disorders. The core feature here is cognitive decline, both subjectively and objectively, which may impact ADLs and IADLs. To differentiate between them, major neurocognitive disorder has significant decline and assistance is required with at least complex IADLs. Mild neurocognitive disorder has modest decline, but individuals are still independent in IADLs and ADLs. So let's go a little bit deeper into the diagnostic criteria for major and mild neurocognitive disorder. For major neurocognitive disorder, there must be a significant cognitive decline in at least one cognitive domain, and this is based off subjective reports, so this can come from the patient, knowledgeable informant, or the clinician, as well as objective reports, so this is based on standardized neuropsychological testing, with a difference of at least 2 standard deviations. This individual will require assistance with at least complex IADLs. It's not due to delirium, and is not due to another mental disorder. Comparatively, mild neurocognitive disorder requires a modest cognitive decline in at least one cognitive domain, and that's based on, again, subjective report, as well as objective report. These individuals are still independent for IADLs and ADLs, although they may need some more assistance with these things. It is not due to delirium, nor is it due to another mental disorder. There are 3 types of specifiers applied in addition to these diagnostic labels. These are specify whether due to. This can be anything from the remainder of this section, for example, Alzheimer's disease or frontotemporal degeneration. Specify with or without behavioral disturbances. So if cognitive disturbance is accompanied by a clinically significant behavioral disturbance, you would code it as such. And specify current severity. So mild is where there are difficulties with IADLs, moderate is where there's difficulties with ADLs, and severe is when individuals are fully dependent. Mnemonic to remember criteria is cognitive domain, so Alzheimer's, so CDSOA. There's a change in the cognitive domain, both subjectively and objectively, and there may be issues with IADLs or ADLs. So let's talk a bit more about ADLs and IADLs with these 2 questions. So what are some of the activities of daily living we usually talk about? And what are some of the IADLs we usually talk about? The mnemonic I use for ADLs is BATTED, which stands for bathing, ambulating, transfers, toileting, eating, and dressing. And the mnemonic I use for IADLs is SCUM, which stands for shopping, cooking and cleaning, using telephone and transportation, and managing money and medications. Our first case is of Francine Reaver. So you're a geriatric psychiatrist working in outpatient practice. You're surprised to see that a 54-year-old woman named Francine Reaver has been referred to your office for assessment. Curious, you review the referral note. Dear Doctor, please see Mrs. Reaver for assessment of behavioral disturbance. Her family reports gradual changes over the past 4 years, including loss of empathy, overeating, and apathy. Concerningly, she has also recently developed OCD and behaves as though drunk during her office appointments. Memory-wise, she seems quite sharp. Her son seems to recall something similar affecting his grandfather who had ALS. I would appreciate your opinion with regards to ongoing management. So what do you think the most likely diagnosis is? And what are the diagnostic criteria for this disorder? So this is a case of frontotemporal dementia. whose core features are progressive development of behavioral and personality change and/or language impairment. Criteria are: person has major or mild neurocognitive disorder. There's an insidious onset and gradual progression. They meet criteria for the behavioral variant or language variant. Behavioral variant has 3 of the 5 following present: apathy, disinhibition, repetitive, or OCD behaviors, orality, loss of sympathy or empathy. And the language variant has 1 of the following 5: difficulties with language production, word finding, naming, grammar and syntax, or comprehension. Individuals have relative sparing of learning and memory, as well as perceptual motor cognitive domains. It is not due to substance, another neurodegenerative disorder, cerebrovascular disease, or another medical condition. In order to have probable frontotemporal dementia, at least 1 of the following 2 is present. Number 1, there's a causative genetic mutation. This can be suggested by family history or genetic testing. Or 2, there's frontal and/or temporal lobe involvement from imaging. For diagnosis of possible frontotemporal dementia, neither 1 or 2 are present. The mnemonic to remember the behavioral variant is bad sore. The B stands for behavioral, A for apathy, D for disinhibition, S for sympathy, O for orality, R for repetitive behavior, and E for empathy. You meet with Mrs. Drever and her son Peter. Upon entering your office, Mrs. Drever flicks the light switch 6 times before taking her seat. Throughout the appointment, she is quite disinhibited and consumes an entire package of sugar-free gum. When you discuss the suspected diagnosis of frontotemporal dementia, Peter is quite distraught. Comparatively, Mrs. Drever seems unfazed and tells Peter to man up, kicking him hard in the shin before chuckling loudly. Rubbing his leg, Peter asks if he could trouble you with some questions about FTD. How prevalent is FTD? Is it more common in men or women? When does FTD normally present, and how long do people live after diagnosis? Are there risk factors I can address to reduce my chances of getting FTD? In answering his questions, how prevalent is FTD isn't more common in men or women. Prevalence is between 2 to 31 per 100,000, and it is as likely to occur in males as it is in females. When does FTD normally present, and how long do people live after diagnosis? FTD normally presents in the 50s, and mean survival is 6 to 11 years after symptoms, or 3 to 4 years after diagnosis. Are there risk factors I can address to reduce my chances of getting FTD? Not really. 40% have family history, 10% show autosomal dominant inheritance. Some genes are associated with FTD, including MAPT, GRN, and CNORF72. Motor neuron disease, such as ALS, is associated with rapid deterioration. These are some additional questions which may come up in exams. What neuroimaging findings are associated with the behavioral variant? Atrophy of frontal lobes as well as anterior temporal lobes. What neuroimaging findings are associated with the semantic language variant? Atrophy of middle, inferior, and anterior temporal lobes, asymmetrically with the left greater than right. What neuroimaging findings are associated with non-fluent language variant? Left posterior frontal insular atrophy. As an additional comment, there is a third form of progressive language decline called logopenic progressive aphasia. This is associated with left temporal parietal dysfunction and is often caused by Alzheimer's disease pathology. So now for the case of Daniel Brown. Mr. Brown is a 74-year-old man who is referred to you for the chief concern of nightmares and psychosis. He is escorted to your office by his nephew, Vernon Drever, Peter's cousin. As you observe him walking up, you see a slow, shuffling gait and some hesitancy to move forward even with Vernon's help. Upon entering your office, you notice that he seems distracted and frequently peers past you to the corner of the room. He seems tired, and towards the end of your assessment, he nods off. You ask Vernon about history of presenting illness, and he shares that for the past couple of years or so, Daniel has been having memory trouble. At first, the family thought maybe it was Alzheimer's, but then he started waking up with bruises on his arms in the morning and talking about seeing small children and animals in the house. More recently, his walk has changed. Our doctors think it's late-onset schizophrenia. What do you think is going on? What do you think is the most likely diagnosis based on the history above? What causes this problem? What is the pathology? Is this the same as Parkinson's disease dementia? How do you tell the difference? So this is a case of dementia with Lewy bodies. The core feature is progressive cognitive impairment with early changes in attention, executive function, and visual spatial ability, as well as recurrent complex visual hallucinations and concurrent symptoms of REM sleep behavior disorder. Criteria are major or mild neurocognitive disorder, insidious onset and gradual progression. They meet the core diagnostic features and supportive diagnostic features. Probable dementia with Lewy bodies means that there are two core diagnostic features or one core diagnostic feature and one supportive diagnostic feature, whereas possible dementia with Lewy bodies means that there is one core diagnostic feature or one supportive diagnostic feature. Core diagnostic features include fluctuating cognition and variation in attention and alertness, well-formed visual hallucinations, and Parkinsonism after cognitive decline. Supportive diagnostic features are REM sleep behavior disorder and neuroleptic sensitivity. This condition is not due to another neurodegenerative disorder, cerebrovascular disease, substance, another mental disorder, another neurocognitive disorder, or general medical condition. In response to what causes this problem, pathology is misfolding and aggregation of alpha-synuclein. And in response to is this the same as Parkinson's dementia, how do you tell the difference? Dementia with Lewy bodies means that Lewy bodies are primarily in limbic locations, plus minus the neocortex, and this leads to cognitive decline early in illness course, whereas in Parkinson's, Lewy bodies start in the brainstem, and this leads to cognitive decline late in the illness course. The mnemonic to remember the core and supported diagnostic features is fine vapor, which stands for fluctuating cognition and variation in attention and alertness, neuroleptic sensitivity, visual hallucinations, Parkinsonism after cognitive decline, and REM sleep behavior disorder. Oh, I see. Thanks, Doc, says Vernon in response to your detailed answer. I don't suppose you'd mind me asking just a few more questions, seeing as you know so much about this. My younger sister Heather is going to have a lot of questions for me, and I want to come prepared. Specifically, how common is dementia with Lewy bodies in someone Uncle Daniel's age? Is it normal for this to start in someone his age? How long can someone live like this? His family doctor wanted to start him on risperidone. Should we go ahead with that? Now let's respond to these questions. How common is dementia with Lewy bodies in someone Uncle Daniel's age? Population estimate is 0.1 to 2% of individuals over the age of 65. In community, it accounts for 4.2% of all dementia cases. It's more often encountered in males at a rate of 3 to 1 compared to females in individuals over the age of 65. Is it normal for this to start in someone his age? Onset often occurs in the mid-70s. How long can someone live like this? The course of this illness has occasional plateaus but eventually progresses to severe dementia and death. Survival is between 5.5 to 7.5 years from the onset of cognitive decline. His family doctor wanted to start him on risperidone. Should we go ahead with that? We should be very careful in using medications like risperidone. People with dementia with Lewy bodies are very sensitive to neuroleptics. Now here are some pearls. These are questions that may appear on exams. What EEG findings are associated with dementia with Lewy bodies? Prominent slow wave activity with periodic fluctuations in pre-alpha theta range. How does DLB appear on SPECT and PET? Low striatal dopamine transporter uptake. What polysomnography findings are associated with DLB? REM sleep without atonia. What are the associated features of DLB? Frequent falls, syncope, autonomic dysfunction, hypersomnia, and hyposomnia. What protein is associated with DLB? TDP43. This is an additional point on TDP43. This is a protein that's been identified as a source of proteinopathies across a range of neurodegenerative disorders, including ALS and frontotemporal degeneration. The presence of multiple pathological lesions has implication for disease prognosis and may be associated with a more rapid cognitive decline and shorter survival time. And so now on to case 10, the case of Andrea Dobson. I've been more forgetful lately, reports Mrs. Dobson. I'm worried that what happened to my father and brother is happening to me. Of course, Brian, my brother, was younger than me when he started having trouble with his memory, and it wasn't long after that he passed away. But my father was about my age. I've heard that people with Brian's condition often have memory trouble earlier than others. Maybe I'm worried for no good reason. Miss Dobson's medical history is significant for hearing impairment, hypertension, diabetes, and major depressive disorder. She has a BMI of 38, and social history is significant for 40-year pack per day smoking history, minimal physical activity, and no close social supports. Brian, her brother, was born with Down syndrome. What disorder is most likely based on the information provided above? And what are the 3 causative gene mutations associated with this condition? So this is the case of Alzheimer's dementia. Core feature is insidious onset and gradual progression of cognitive behavioral symptoms. Typically, patients are amnestic, that is, they have impairments in learning and memory. Criteria include major or mild neurocognitive disorder, insidious onset and gradual progression, probable or possible Alzheimer's disease corresponding to the following criteria. So, probable major neurocognitive disease, Alzheimer's type, if one of the 2 following are present, or possible if 0 to the 2 are present. So 1 is evidence of causative genetic mutation, and 2 is 3 out of 3 of the following. So decline in learning and memory in one other cognitive domain, gradual progression without plateaus, and not due to mixed etiology. It is mild, probable Alzheimer's if evidence of causative genetic mutation is present, and it is mild possible Alzheimer's if all three of the following are present: so decline in learning and memory and one other cognitive domain, gradual progression without plateaus and not due to mixed etiology. In response to the question, what are the three causative gene mutations associated with this condition? They are amyloid precursor protein, this is located on chromosome 21, presenilin 1 or PSEN1, located on chromosome 14, and presenilin 2 or PSEN2, located on chromosome number 1. The only additional risk factor not mentioned in the case is low educational status, although some genetic risk may come from Li206A1A and ABCA7. Thanks for the information, Doctor. I'm afraid it has done little to ease my mind. Can you tell me more about Alzheimer's disease? Specifically, how common is Alzheimer's disease? How does Alzheimer's disease typically progress, and how long do people survive with this condition? Can't you do a scan to tell whether or not I have this condition? If not, how can you come to a definitive diagnosis? So we'll take each of her questions in turn. So how common is Alzheimer's disease? 5 to 10% of people between the ages of 60 and 69 are afflicted, 25% of people over the age of 70, and 32% of people greater than the age of 85. How does Alzheimer's disease typically progress, and how long do people survive with this condition? It most often begins with progressive amnesia. Later, social cognitive deficits occur. Survival is about 10 years after diagnosis. The most common cause of death is aspiration. Can't you do a scan to tell whether or not I have this condition? If not, how can you come to a definitive diagnosis? No scan is available to make the diagnosis. Definitive diagnosis is based on pathology. There are 3 hallmark features of Alzheimer's disease for pathological diagnosis. They are, number 1, amyloid predominant neuritic plaques, number 2, tau predominant neurofibrillary tangles, and number 3, neuronal loss, either microscopically or manifested in regional cortical atrophy. As a pearl and an exam question, why can't ApoE4 be used as a diagnostic marker for Alzheimer's? Because it is a risk factor. That is, it is neither necessary nor sufficient for disease occurrence. And now on to case 11, the case of Vernon Drever. You're rotating on neurology and have been asked to assess a 63-year-old man for memory problems, which staff and family noticed 3 weeks ago following admission to the neurosurgical unit for management of a hemorrhagic stroke. In preparation for meeting Mr. Drever, you review the CT scan from admission and compare it with the one completed this morning. Shows significant improvement following neurosurgical intervention. Mr. Drever's history is significant for essential hypertension, dyslipidemia, diabetes, and obesity. He is a pack per day smoker and has family history of cerebrovascular disease. What is the most likely diagnosis based on the above history? If the suspected diagnosis is vascular dementia, which 2 cognitive domains are most likely to be impacted? What are the risk factors for developing vascular dementia? What about protective factors? How common is vascular dementia? So the core feature of vascular dementia is an established connection between neurocognitive deficit and cerebrovascular event. Criteria include the presence of major or mild neurocognitive disorder, evidence of a vascular etiology supported by at least one of the two following. Number one, temporality. The neurocognitive disorder follows the cerebrovascular event. And number two, sharp decline in complex attention or executive function. And the cerebrovascular disease is sufficient to account for the neurocognitive disorder. It is not due to another neurocognitive disorder or a general medical condition. In responding to the question about risk factors and protective factors for vascular dementia, risk factors include hypertension, diabetes, smoking, high cholesterol, obesity, high homocysteine, cerebral amyloid angiopathy, and CADASIL. Protective factors are related to neuroplasticity and include education, exercise, and sustained mental activity. In responding to the question, how common is vascular dementia? 1% of adults aged 71 to 79 are afflicted, 4% of adults aged 80 to 89, and 6% of adults over the age of 90. It's more common in males than females, and in non-white people versus white people. It is much more common after the age of 65, and it is the second most common cause of neurocognitive disorder. The attending neurologist thanks you for seeing Mr. Drever and engages you in conversation. Neurologist. So, you think it's vascular dementia? Yeah, that's pretty obvious. Tell me, what are the 4 clinical subtypes of vascular dementia? Can I just go home now? I'm tired. Neurologist. No, you cannot go home. Also, what imaging evidence would support the diagnosis of vascular dementia? Hypothetically. We'll answer each of this guy's questions. So, what are the 4 clinical subtypes of vascular dementia? Number 1, post-stroke neurocognitive disorder. Symptoms occur right after the stroke. Number 2, subcortical ischemic neurocognitive disorder. Number 3, multi-infarct or cortical neurocognitive disorder. And number 4, cortical subcortical vascular neurocognitive disorder. What imaging evidence would support the diagnosis of vascular dementia? Number 1, large vessel infarcts or hemorrhages. Number 2, well-placed infarct or hemorrhage. Number 3, 2 or more lacunes outside the brainstem. And number 4, extensive and confluent white matter lesions, also known as small vessel disease or subcortical ischemic changes. Okay, on to case 12, the case of Peter Drever. You're visiting your patient Francine Drever in long-term care, where she's been living for the past several months after being diagnosed with frontotemporal dementia. Normally, Peter attends your follow-up appointments, but today he's nowhere to be found. After your appointment, you call his home to check in on him and ask about his mother. You learn from his daughter Tabitha that he was recently admitted to the hospital after having difficulties with sleep, appetite, concentration, fatigue, and anxiety in addition to memory problems. You're surprised to hear this, as when you last saw Peter a month ago, he seemed to be doing very well. In fact, he had just been promoted to a floor supervisor at the meat processing plant where he worked. He was always keenly attentive to your conversations, and in fact, you suspected him of having superior autobiographical memory. His daughter is quite concerned and asks you if people with the kind of problems Peter's having often have trouble walking and are startled easily. She recalled shutting the car door at the hospital, and Peter began to shake as if terrified. Based on the above information, what do you think is the most likely diagnosis? What is the typical course of this disorder? So this is the case of prion disease dementia. Core feature is neurocognitive disorder due to subacute spongiform encephalopathies caused by prions. This presents with ataxia and abnormal movements, such as myoclonus, chorea, or dystonia, and often an exaggerated startle response. Criteria include major or mild neurocognitive disorder, insidious onset and rapid progression, motor features of prion disease or biomarkers, and is not due to a general medical condition or another mental disorder. In responding to the question, what is the typical course of this disorder? Prodromal symptoms may include fatigue, anxiety, problems with appetite or sleeping, and difficulties with concentration. Several weeks later, incoordination, altered vision, or abnormal gait or movements occur along with rapidly progressive dementia. As a pearl, biomarkers are not needed in the presence of motor features, but increase confidence that neurocognitive disorder is due to prion disease greatly if present. Several days later, you are walking into work when you bump into Tabitha in the main hospital mall. From her appearance, you can tell she's been sleeping poorly. You offer to buy her a coffee, and she informs you that she's on her way to visit her father. You look at your watch to see that you still have some time before your first patient. You ask to join her, and she agrees. On the elevator ride up to the 6th floor, Tabitha has some questions for you about prion disease. How common is prion disease dementia? And how is the diagnosis of prion disease confirmed? Will I get prion disease dementia too? And I will take each of her questions in turn. How common is prion disease dementia? Prevalence is low, given the short survival. It is 1 to 2 per million. The incidence is 5 per 100,000, and it's more common in people over the age of 65 and in white people. Incidence of prion disease dementia peaks at 67 years of age. How is the diagnosis of prion disease confirmed? The only way to do so is via brain biopsy or an autopsy. The most specific test for prion disease is real-time quaking-induced conversion, or RT-QuIC. It's used to amplify small amounts of disease-causing prion proteins from CSF and has extremely high specificity. The most sensitive test for prion disease is MRI with DWI. Most commonly, this shows multifocal gray matter hyperintensities in subcortical and or cortical regions. Another very commonly tested, highly sensitive test for prion disease is 1433 and tau. These are CSF markers of neural injury. They have quite low specificity for prion disease. Will I get prion disease dementia too? 15% of cases are autosomal dominant mutations in prion protein gene PRNP, which encodes for normal bound protein. The codon 129 polymorphism of PRNP mediates the risk for sporadic and acquired prion disease, as well as modifies clinical manifestations, age at onset, and disease duration. As a pearl, EEG findings associated with prion disease include periodic, sharp, often triphasic, and synchronous discharges at a rate of 0.5 to 2 Hz, occurring at some point during the disorder. Case 13, the case of Tabitha Drever. You are the staff psychiatrist on call, and it's a particularly busy shift. You've come in to help your residents with the overwhelming number of consults. You're speaking to an emergency physician who graduated from the same medical school class as you when trauma team to emergency is repeated loudly over the hospital intercom. Moments later, you see a woman wheeled into the trauma bay, her head wrapped in gauze, clothing soaked in blood. As you linger at the trauma bay curtain, the trauma team begins to review the patient's history and unwrap the gauze wrapped around her head. Your face drains of blood and a sickening feeling grips your stomach. You know this woman. It's Tabitha Drever. You soon learn that whilst driving home from her father's funeral, she became caught in a sudden rainstorm and lost control of the wheel, rolling her car several times. Several months later, you receive a consult from the rehabilitation unit to assess a young woman whom you soon recognize as Tabitha Drever for the concern of memory impairment following traumatic brain injury. What are the diagnostic criteria for traumatic brain injury dementia? The core feature is acquired and persistent neurocognitive disorder resulting from TBI. Criteria include major or mild neurocognitive disorder and evidence of TBI along with one of the following four. Number 1, loss of consciousness. Number 2, post-traumatic amnesia. Number 3, disorientation and confusion. And number 4, neurological signs such as a focal neurological deficit or findings on CT. The neurocognitive disorder occurs immediately after the TBI and persists. Mnemonic for evidence of TBI and the 4 associated symptoms is dance, standing for disorientation, amnesia, neurological signs, and loss of consciousness. There's some additional questions, because no one is around to ask you them. What are the risk factors for adverse cognitive outcomes after TBI? They are age over 40, previous cognitive ability, previous depressive symptoms, previous unemployment, injury severity, post-traumatic amnesia, intracranial abnormality on CT or MRI early in the course of illness, and pre-injury alcohol use disorder or other substance use disorders. What factors impact recovery from traumatic brain injury? These include age, prior history of TBI, comorbidities, genetics, timeliness and effectiveness of intervention, and psychological support. How common is TBI? For males, it is 5.5 in every 1,000. For females, 3.8 in every 1,000. It's more common in males under the age of 75, and after 75, males and females are equally afflicted. What are the common causes of TBI? They are falls, collisions, MVCs, assault, and concussion. On to case 14. This is the case of Heather. Heather is a 40-year-old female. She's been referred to you for assessment of cognitive impairment. She attends her appointment along with her husband, Mike. In examination, Heather exhibits wild flailing movements and has difficulties following your conversation. Through your expert examination and history taking, you are able to detect significant impairment in executive function, which vastly outclasses issues with learning and memory. Heather is able to recall her mother being similarly afflicted as well as her older brother. Mike reports that Heather hasn't been herself for several years and expresses concern that his children may acquire this disorder. What is the most likely diagnosis? And how would you respond to Mike's concern? So this is the case of Huntington's disease dementia. The core feature is progressive cognitive impairment The early changes in executive function, more so than learning and memory. Cognitive and behavior changes often precede motor abnormalities. Criteria include the presence of major or mild neurocognitive disorder, insidious onset and gradual progression, diagnosis of Huntington's disease, or family history, or evidence from genetic testing. It is not due to another medical condition or another mental disorder. And in responding to Mike's concern, you may explain the genetics. Huntington's disease is passed through autosomal dominant expression of a CAG trinucleotide repeat in the Huntingtin gene. Repeat lengths of at least 40 are invariably associated with Huntington's disease. Repeat lengths of 36 to 39 are considered partially penetrant, as they may or may not cause Huntington's disease, and if they do, then it's usually in later life, typically after the age of 70. Mike: Thanks, Doc. I guess we should let the kids know about the diagnosis. Perhaps when they're older, they'll want to undergo genetic testing to determine their risk. Is it okay if I ask a few more questions? Specifically, what is the normal course of illness in Huntington's disease dementia? What's the prevalence of Huntington's disease dementia? Heather suffered from depression when she was younger. Is there any risk of suicide in Huntington's disease? Are you absolutely sure this is Huntington's disease? How could you be more sure? And now we'll take each of his questions in turn. So what is the normal course of illness in Huntington's disease dementia? Onset is usually between 35 to 45 years of age. Individuals with longer expansion lengths, that is greater than 36, have earlier onset. Survival is between 10 to 20 years. This is variable, with death usually coming from aspiration pneumonia. What's the prevalence of Huntington's disease dementia? It's 2.7 per 100,000 worldwide. In North America, it's 5.7 per 100,000. It's much lower in Asia at 0.40 per 100,000. Heather suffered from depression when she was younger. Is there any risk of suicide in Huntington's disease? Yes, suicide is a leading cause of death in Huntington's disease. Increased SI occurs both prior to and after manifesting motor symptoms. Risk factors for this include depressive symptoms, anxiety, psychosis, and apathy. Suicide accounts for 6.6% of deaths in this population. Are you absolutely sure this is Huntington's disease? How could you be more sure? There are two requirements for definite Huntington's disease. They are 1, unequivocal extrapyramidal motor abnormalities, and 2, family history of Huntington's disease or genetic testing showing the CAG trinucleotide repeat expansion of the HTT gene on chromosome 4. And a couple of pearls for Huntington's disease dementia. What neuroimaging findings are associated with Huntington's disease? There's volume loss in the basal ganglia, especially the caudate nucleus and putamen. And how does juvenile Huntington's disease differ in presentation compared to later onset? More commonly presents with bradykinesia, dystonia, and rigidity as opposed to choreic movements. And for emphasis here, diagnosis of Huntington's disease is not made in the presence of gene expansion alone. Diagnosis is made only after motor symptoms become manifest. And now on to case 15, the case of Harvey Isbister. You're working at an inner-city clinic when one of the nurse practitioners enters your office with an informal consult. Tells you about one of his patients, Harvey Isbister, a 62-year-old man living transiently, supported by social assistants with history of IVDU and major depressive disorder. Nurse practitioner. Hate to bother you, but I think Mr. Isbister has Alzheimer's. It's odd, though. Sometimes his memory seems so sharp. Several times I've seen him over the past 2 years, his thought process seems so slowed down. He was trained as a carpenter in earlier life, but 2 weeks ago when we had a naloxone training session at the clinic, he had so much difficulty figuring out how to set up his equipment that he got frustrated and left. I wondered if he'd been using again, but urine tox and other basic tests were all normal. What do you think is going on? Based on the above history, what do you think is the most likely diagnosis? Now, what are the typical changes seen in this type of dementia? What risk factors, if present, would increase your suspicion for this disorder? So this is the case of HIV dementia. Core features are neurocognitive disorder caused by HIV-1, which generally shows a subcortical pattern, characterized by mental slowing and motor dysfunction. Procedural learning and free recall deficits also occur, but there's relative sparing of recognition, memory, verbal abstraction, and naming. Criteria include the presence of major or mild neurocognitive disorder, HIV infection. It's not more likely non-HIV neurocognitive disorder or secondary brain disease, such as cryptococcal meningitis or leukoencephalopathy. It's not due to another mental disorder or a general medical condition. In response to what risk factors, if present, would increase your suspicion for this type of dementia? Risk factors for neurocognitive disorder in HIV include prior episodes of immunosuppression, high viral loads in CSF, increased amount of any of the following in CSF, so TNF-alpha, interleukin-6, CRP, D-dimer, SCD14, SCD163, and neurofilament light chain, as well as advanced HIV, such as low CD4 cell nadir anemia or hypoalbuminemia, older age, lower education level, female sex, major depressive disorder, alcohol use disorder, other substance use disorders, diabetes, and hypertension. Nurse practitioner. Wow, maybe I should make this a formal consult. Sounds like you know a lot about HIV dementia. I've heard other practitioners talk about asymptomatic neurocognitive impairment in HIV. Is that the same thing or something different? What can I tell Mr. Isbister to expect in terms of course of illness? Will this condition have any impact on Mr. Isbister's antiretroviral therapy? Is he going to die? You. That's a lot of questions. Let me take each of them in turn, except that last one. So what is asymptomatic neurocognitive impairment in HIV? 33 to 50% of HIV-infected individuals have at least some evidence of neurocognitive disturbance. Most of these disturbances would not meet criteria for mild neurocognitive disorder, but would instead represent asymptomatic neurocognitive impairment. They may have substandard performance on one or more of the tests of neurocognitive abilities, but do not have any impairment on functional status. What is the expected course of illness in HIV dementia? Course is variable, can resolve, improve, slowly or rapidly worsen, or have a fluctuating course. Rapid progression is, however, uncommon. Eventually, there is an interaction between the subcortical neurocognitive profile of HIV dementia and aging. What is an important functional consequence of HIV dementia? Impaired executive function and slowed information processing may interfere with adherence to effective ART. That being said, ART may be associated with inflammation, neurotoxicity, and metabolic changes which lead to vascular compromise and indirectly worsen neurocognitive impairment. And now on to case 16, the case of Parker's son. You're rounding on patients at a long-term care home and have been asked to check in on Parker's son, a 94-year-old gentleman diagnosed with Parkinson's disease 10 years ago, whom we've been following for the past 7 years. In earlier life, Mr. Sun worked as a ranch hand and had a particular knack for fixing machinery and painting outbuildings. He retired at 68 after he fell from scaffolding and sustained a mild TBI. From the nursing staff, you learn that he's been experiencing more difficulty swallowing and feeling lightheaded since your last visit. In meeting Mr. Sun, you find his gait has deteriorated and he appears sleep-deprived. Despite dysphonia, he reports restless sleep and waking up with bruises on arms and legs. What are the criteria for Parkinson's disease dementia? What findings in neuropsychological testing would support Parkinson's disease dementia? And finally, what risk factors in Mr. Sun's history increase likelihood of developing Parkinson's disease dementia? Are there any others that aren't present? The core feature of Parkinson's disease dementia is cognitive decline at the time of or following onset of idiopathic Parkinson's disease. Criteria include major or mild neurocognitive disorder, Parkinson's disease, insidious onset and gradual progression, and it's not due to a general medical condition or other mental disorder. Probable Parkinson's dementia means that 2 out of the 2 following are present. Possible means that 1 of the 2 are present. Number 1, no evidence of mixed etiology, and number 2, Parkinson's disease precedes neurocognitive disorder. In responding to what findings in neuropsychological testing would support Parkinson's disease dementia, there are 5. Number 1, reduced attention. Number 2, executive dysfunction. Number 3, memory deficit. Number 4, slowed information processing. Number 5, visual spatial function deficits. In responding to the question, what risk factors in Mr. Sun's history increase likelihood of developing Parkinson's disease dementia, and are there any others? In his history, they are exposure to pesticides and solvents, TBI, older age at onset of Parkinson's disease, prominent gait symptoms, autonomic disturbances, and REM sleep behavior disorder, in addition to male sex. Others include severe Parkinson's disease, lower level of education, presence of the glucocerebrosidase gene, and ApoE4. The mnemonic to remember the neuropsychological testing findings supporting the Parkinson's disease dementia diagnosis is REMS V, and it stands for reduced attention, executive dysfunction, memory deficit, slow information processing, and visual spatial function deficits. Over the lunch hour, you meet up with one of your colleagues, Dr. Know-It-All, and you discuss your morning. Dr. Know-It-All grins and decides to begin quizzing you on Parkinson's disease dementia. She asks you the following questions. How prevalent is Parkinson's disease dementia? What is the typical course of Parkinson's disease and related dementia? How might Lewy body dementias be differentiated from non-Lewy body dementias with lab techniques? Although this is probably the last time you ask Dr. K to eat lunch with you, you reluctantly respond. How prevalent is Parkinson's disease dementia? 0.4% of adults aged 60 to 69 are afflicted. 1.4% of adults aged 80 to 89 are afflicted. Parkinson's disease prevalence is higher in males than in females, although it's not clear whether the incidence is higher. And Parkinson's disease dementia is more common in males. What is the typical course of Parkinson's disease and related dementia? Parkinson's disease onset is typically between 50 to 89, most often in the 60s, and mild neurocognitive disorder is quite common early following diagnosis of Parkinson's disease. Eventually, major neurocognitive disorder develops in 80% of patients, while 25 to 27% remain mild. How might Lewy body dementias be differentiated from non-Lewy body dementias with lab techniques? Dopamine transporter scans, such as DAT, may help differentiate between Lewy body dementias, that is, dementia with Lewy bodies, and Parkinson's disease dementia, and non-Lewy body dementias. I bet you think you're pretty smart, scoffs Dr. Know-It-All, but I'm not through with you yet. What are the 7 most common comorbidities associated with Parkinson's disease dementia? What other features might be associated with Parkinson's disease dementia? Angry but not willing to admit defeat, you answer Dr. K's questions. So what are the 7 most common comorbidities associated with Parkinson's disease dementia? These are Alzheimer's disease, cerebrovascular disease, motor symptoms, depression, psychosis, REM sleep behavior disorder, and apathy. What other features might be associated with Parkinson's disease dementia? Apathy, depressed mood, anxious mood, hallucinations, delusions, personality changes, REM sleep behavior disorder, excessive daytime sleepiness, freezing of gait, falls, bilateral involvement early in disease, postural instability and gait disturbance, and hyposomnia. Just as a bonus point, I don't know if this would ever come up anywhere, but what is Guam dementia? So this is late onset neurocognitive disorder occurring in 8.8% of Chamorros, age 65 plus. Neurofibrillary tangles are present, but without amyloid plaques. It's thought to be related to a unique Parkinsonian dementia complex in ALS. It's associated with processing and eating fadang, which is made with cycad seeds. On to case 17, the case of Stanley Magnuson. It's 15:30 and you're working crisis call in the emergency department when your phone rings. ACAL connects you to a medical student working in Rosetown who relays the following history. Hi, Dr. Psychiatrist. I have a 70-year-old patient, Stan Magnuson, here with Alzheimer's disease. His history is significant for chronic alcoholism since his teens. He's been admitted to the medicine ward a number of times to manage withdrawal. Otherwise, he's chronic liver disease. And he had cabbage when he was 58. He's pretty unsteady on his feet, and his Alzheimer's must be pretty severe because every time I go into his room, he seems to forget who I am. Once I explain we've met before, he pretends to remember me and makes stuff up. Attending told me to call you for advice. What do you think we should do? What is the most likely diagnosis, and what are its corresponding DSM-5 criteria? What can you tell your medical student colleague about the course of illness for this condition? What about its pathology? So this is a case of substance or medication-induced dementia, core feature being neurocognitive impairment that persists beyond the usual duration of intoxication and acute withdrawal from a medication or substance. Criteria include major or mild neurocognitive disorder. It's not due to delirium, intoxication, or withdrawal. The substance or medication used and the duration and extent are able to cause neurocognitive impairment. And there's temporality. The neurocognitive disorder corresponds to use and abstinence. It's not due to another medical condition or another mental disorder. Responding to the question, what can you tell your medical student colleague about the course of illness for this condition? You could answer, substantial, even complete recovery of function is common if there is stable abstinence before the age of 50. Afterwards, prognosis worsens, especially bad if concomitant substance use disorders and with early or heavy use of the substance. Aging interacts poorly with alcohol-induced brain injury. Initially, manifestations reflect slow recovery of brain function from prolonged use. Eventually, this becomes persistent. And what about its pathology? More specifically for Korsakoff's, there is impairment in recent memory out of proportion to other neurocognitive symptoms, prominent amnesia. This is prospective with rapid forgetting. There's a tendency to confabulate. It's not specific. This can be seen with any severe diminution of recent memory and may occur alongside thiamine encephalopathy. Medical student. Oh wow, so you think this is related to his long-standing alcohol use and it's called substance medication-induced dementia? That's a new one for me, but I wonder, would it be okay if I asked you some more questions about it? Specifically, what are the risk factors for SMID in general and alcohol-induced neurocognitive disorders in particular? Is it common? What is thiamine encephalopathy and how does it present? There are laboratory or imaging findings which can support alcohol-induced neurocognitive disorder. So we'll take each of his questions in turn. What are the risk factors for SMID in general and alcohol-induced neurocognitive disorder in particular? In general, it's more likely those who are older, have longer duration of use, persistent use past the age of 50, as well as nutritional deficiencies. For alcohol-induced neurocognitive disorder in particular, long-term nutritional deficiencies, liver disease, vascular risk factors, cerebrovascular, cardiovascular disease, and genetic transketolase deficiency are associated. Is alcohol-induced neurocognitive disorder common? 30 to 40% have mild neurocognitive disorder in the first 2 months of abstinence, with worse prognosis and recovery after the age of 50. Major neurocognitive disorder is rare, but when it does occur, it's more common in males than females. What is thiamine encephalopathy and how does it present? The other name for this condition is Wernicke's. It presents with a triad of nystagmus, ataxia, and ophthalmoplegia, or lateral gaze paralysis. Are there laboratory or imaging findings which can support alcohol-induced neurocognitive disorder? Laboratory findings might suggest end organ damage due to chronic alcohol use. MRI findings for alcohol-induced dementia are not entirely specific, but include cortical thinning, white matter loss, and enlargement of cell-sign ventricles. Be cautious in interpreting these findings as they may not be present. Someone can still have alcohol-induced neurocognitive disorder without them. The opposite may also be true. Okay, so just some pearls for substance and medication-induced dementia. So risk factors for sedative, anxiolytic, hypnotic-induced neurocognitive disorder have not been well studied. They might include long-term anxiety disorders and long-term sleep problems, given their association with these types of medications. Neuroimaging findings associated with methamphetamine-induced dementia on MRI include MRI hyperintensities, which suggest microhemorrhages or large areas of infarction. This table details some of the associated neurocognitive changes depending on the specific substance as well as associated features. I'm not going to go through this here, but if you wish, you can come back to this slide and review this on your own. And now on to case 18, the case of Madame C. Medical student. Wow, thanks, Dr. Psychiatrist. I guess not all memory problems are Alzheimer's. While I have you on the line, mind if I ask you another question about a patient I saw while rotating through neurology at the University Hospital? You? Sure, go ahead. Thanks. Well, we admitted this 50-year-old lady, Madame C, with poorly managed MS, and it was really strange. At first we thought she had Alzheimer's, but over the course of the admission, her memory seemed to get a bit better. Attending was pretty convinced it wasn't delirium. Is that the kind of thing that would normally happen with someone who has MS? What is the diagnosis your medical student is most likely describing? What about its DSM-5 criteria? What finding in history increases your diagnostic certainty of this diagnosis? So this is the case of dementia due to another medical condition, the core feature being a temporal association between onset or exacerbation of a general medical condition and neurocognitive disorder. Criteria include presence of major or mild neurocognitive disorder. Neurocognitive disorder is the consequence of the general medical condition. It's not due to another mental disorder or another neurocognitive disorder. In responding to what finding in the history increases your diagnostic certainty. Diagnostic certainty may be increased if the neurocognitive disorder ameliorates partially or stabilizes once the general medical condition is treated, such as in the case described by our medical student. And in responding to, is this the kind of thing that normally happens in MS? The prevalence of dementia due to another medical condition is difficult to approximate. It likely varies depending on the diagnosis. I'm not sure about MS, and this isn't mentioned in DSM. Of course, is variable and depends on progression of the underlying general medical condition. If it's treatable, a neurocognitive disorder may improve or at least not progress once treated. If the general medical condition has a deteriorating course, then worsening is more likely. And just as a pearl, these are some possible causes of dementia due to another medical condition. They include brain tumors, SDH, NPH, heart failure, hypothyroidism, hypercalcemia, hypoglycemia, niacin deficiency, thiamine deficiency, neurosyphilis, cryptococcus, temporal arteritis, SLE, hepatic or renal failure, Couff's adrenal leukodystrophy, storage diseases, epilepsy, and MS, as in our case. And now to round things off with case 19 and 20. This is the case of Melanie and Eunice. It's another busy night on call. You're a staff psychiatrist working with 2 residents in the emergency department. An hour or 2 ago, you got 2 calls from one of the emergency physicians about 2 patients with the chief concern of memory impairment. After gathering as many details as you could, you notified your residents and asked that they get started with Melanie and Eunice, ages 72 and 74. Resident 1. Hi, Dr. Psychiatrist. I've just seen Melanie who has a history of mild neurocognitive disorder, Alzheimer's type, and severe alcohol use disorder. Private care home brought her in as they couldn't handle her anymore. She doesn't meet criteria for another mental disorder, and labs are clear. She'll need to be admitted, but I'm not sure what to put down as the admission diagnosis. In this case, what would you put down as the admission diagnosis? What are the DSM-5 criteria? Are there criteria? In thinking about this, you decide to put resident number 1 on hold and answer the call from resident number 2. Hi, Dr. Psychiatrist. Oh man, Eunice is quite out of control. The psychiatric nurse spoke with her husband Robert earlier today, and it sounds like she's had a 4-year history of cognitive decline. Unfortunately, I wasn't able to reach him through telephone, and Eunice won't engage in history taking. Sounds like she needs admission, but I'm not sure what to put down as the admission diagnosis. Labs are clear. Similar to case 1, in this case, what would you put down as the admission diagnosis? What are the DSM-5 criteria? Are there criteria? So first we'll answer resident 1's question about Melanie. So in this case, what would you put down as the admission diagnosis? What are the DSM-5 criteria? So I would put down dementia due to multiple etiologies. Criteria are the presence of major or mild neurocognitive disorder and evidence of more than one cause, not due to another mental disorder or delirium. And for resident 2, in the case of Eunice, there are no criteria per se for this diagnosis, as this would be dementia unspecified. Here there are symptoms characteristic of a neurocognitive disorder which result in clinical distress or functional impairment. Criteria are not met for any of the other neurocognitive disorders discussed above. We use this when the precise etiology cannot be identified with sufficient certainty to make an etiological attribution. And that's the end of the presentation. And now we'll summarize. So the main difference between major and mild neurocognitive disorder is the degree of cognitive decline. In major, it's significant and associated with dependence on others, and in mild, it's modest with independence intact. Specifiers include the specific etiology, the presence of behavioral disturbances, and severity. Criteria for both major and mild neurocognitive disorders include changes in at least one cognitive domain. 6 cognitive domains are remembered with mnemonic P cells, which stands for perceptual motor, complex attention, executive function, learning and memory, language, and social cognition. Delirium is the acute onset of disturbed attention or awareness accompanied by a change in cognition that is not better explained by major or mild neurocognitive disorder or coma, is the pathophysiological consequence of another condition. Specifiers for delirium include the cause, the type, that is level of activity and acuity. ADLs can be remembered via the mnemonic BATTED, which stands for bathing, ambulating, transfers, toileting, eating, and dressing. And IADLs can be remembered via the mnemonic SCUM, which stands for shopping, cooking, cleaning, using the telephone, transportation, and managing money and medications. The core feature of frontotemporal dementia is progressive development of behavioral and personality change and/or language impairment. Core feature of dementia with Lewy bodies is progressive cognitive impairment with early changes in attention, executive function, and visual spatial ability, as well as recurrent complex visual hallucinations and concurrent symptoms of REM sleep behavior disorder. Core feature of Alzheimer's dementia is insidious onset and gradual progression of cognition and behavioral symptoms. Patients are typically amnestic, that is, with impairment in learning and memory. Core feature of vascular dementia is an established connection between neurocognitive deficit and a cerebrovascular event. And the core feature of prion disease dementia is that it is caused by subacute spongiform encephalopathies from prions. It presents with ataxia and abnormal movements such as myoclonus, chorea, or dystonia, and often exaggerated startle response. Core feature of traumatic brain injury dementia is an acquired and persistent neurocognitive disorder resulting from TBI. Core feature of Huntington's disease dementia is progressive cognitive impairment with early changes in executive function, more so than in learning and memory. Cognitive and behavioral changes often precede motor abnormalities. Core feature of HIV dementia is neurocognitive disorder caused by HIV type 1, which generally shows a subcortical pattern. It is characterized by mental slowing and motor dysfunction, procedural learning and free recall deficits, with relative sparing of recognition, memory, verbal abstraction, and naming. Core feature of Parkinson's disease dementia is cognitive decline at the time of or following the onset of idiopathic Parkinson's disease. Core feature of substance and medication-induced dementia is neurocognitive impairment that persists beyond usual duration of intoxication and acute withdrawal from medication or substance. The core feature of dementia due to another medical condition is the temporal association between onset and exacerbation of a general medical condition and neurocognitive disorder. Diagnosis of dementia due to multiple etiologies is used in cases when there is evidence of more than one cause contributing to neurocognitive impairment. Diagnosis of dementia unspecified is used when symptoms characteristic of a neurocognitive disorder are present and result in distress or dysfunction, but criteria are not met for any of the above neurocognitive disorders, and when precise etiology cannot be identified. Once again, the objectives of this presentation were: number 1, to list the 6 cognitive domains and name at least one element of each. Number 2, to become familiar with the DSM-5 criteria for delirium and specifiers. Number 3, to become familiar with prevalence and risk factors for delirium. And number 4, to become familiar with DSM-5 criteria for major and mild neurocognitive disorder and associated specifiers. So that's the end. Thanks everyone for your attention. The only reference I used was the DSM-5 TR. If there are additional questions, you can reach me by email. Thanks very much for your attention today, and have a great day.